asleep or not. So cool. So we'll start with this one, which is the Paddy Dixon CT assessment of nasal sinus compartment and nasal conchobular involvement in 300 cases of sinus disease. I can just find the actual paper. Okay, so this paper kind of started by talking about the use of CT enabling greater diagnostic accuracy of sinonasal and dental disorders. And what they talk about is, I mean, they've published a lot on conchobullae anyway, so that there's been frequent concurrent nasal disorders detected with CT, including conchobular infections, sinonasal fistulae, and things like that. They argue that CT is very useful to identify nasal conchobular empyema, distortion, or absence. And then they go on to talk about whether or not this distortion is a sequel to disease or whether actually it's a congenital abnormality, because you do see those horses that haven't got current sinonasal disease that have distortion or absence of the bullae. So that was one of their aims, was to look at whether or not that could potentially be a sequel to disease, or whether it's a congenital or developmental disorder. And then the other thing they comment on is that there's limited information on which sinus compartments are most commonly involved in sinusitis. The one large-scale study suggested that both maxillary sinuses and the ventral conchal sinus were important, whereas another study showed that only the rostral maxillary and ventral conchal sinus was important. So their aim was to retrospectively examine CT images from horses with confirmed unilateral sinus disease. They used unilateral because they wanted to use the unaffected side as a control. They wanted to identify which sinus compartments were involved, identify whether there was any empyema destruction or loss of the nasal conchobullae. And they only used clinical case horses. They didn't have any controls. They actually used the horses as their own controls. They had data from 3 clinics. So they had Edinburgh, Rossdale's, and the RVC. So they used 100 recent consecutive cases of clinically confirmed sinus disease. So they had equal proportions from each clinic. They re-examined the CTs, one author per institution, to specifically detect which sinus compartments were involved and to detect whether or not there was nasal conchobular involvement. If there were cases that were equivocal, they discussed them between themselves and they reached a consensus. And they recorded the clinical cause of sinusitis for each case from the clinical records. So whatever the surgeon or clinician in charge of the case had decided was the cause of the sinusitis, they recorded. So they examined the CT images for inflammation of the individual sinus compartments, and they defined inflammation as soft tissue or fluid accumulation. They recorded that per compartment, so rostral maxillary, ventral conchal, caudal maxillary, conchofrontal, sphenopalatine, ethmoid. So they actually individually recorded the sinuses. And they examined all cases for any alteration of the nasal conchobullae, and they looked at both the affected sides, the ipsilateral side and the unaffected contralateral side. If they had fluid or fluid and gas attenuation within the bulla, they termed that empyema. And if they felt that the bullae were deformed or absent, they determined that damage. So literally it was a binary, either had empyema or not, it was either damaged or not. There was no it was a little bit atrophied. There was no grading of it. They noted that the caudal aspects of the nasal conchobullae adjacent to infected ventral conchal and rostral maxillary sinuses sometimes showed localized swellings of the walls caudally, but no fluid material rostrally, and they were otherwise normal. So they recorded those ones as normal. There's a diagram, there's an example image in a minute. And the other thing they noted was that nasal conchobullae that were adjacent to erupting cheek teeth were often compressed mediolaterally, and they termed those normal as well. So these were just a few images of what they were looking at. So this is a normal nasal conchobulla. They described this one as an enlarged ventral conchobulla causing compression of the dorsal. From that image myself, I think it's just stuff in the region, but I assume if you follow it backwards and forwards, you probably can determine which is which. C is soft tissue fluid attenuation within most of the ventral conchobulla and ventrally in the dorsal conchobulla. D is soft tissue filling the entire ventral conchobulla, thickening of the bony conchae, and soft tissue fluid attenuating material in the adjacent sinuses. And then we've got dorsal conchobulla affected there and the ventral conchobulla affected there. This is looking at the distortion or destruction. So they would grade as moderate to severe, not that they graded them in this study. This is a, let's see, absent left dorsal conchal bulla. That's an absent ventral conchal bulla. And then E, loss of the left ventral conchal bulla with distortion, atrophy of the lateral portion of the right. And then that's both distorted. So they would all have been classified as damaged or distorted. So they didn't really do any differentiating for those. This picture annoys me because the head's on a wonk, and you'd hope that they would have straightened it out, but that's just me being me. This is what they're talking about with thickening of soft tissue adjacent to the ventral conch, the affected sinus, but actually not having anything rostrally. So I think, to me, this is within the nasal cavity on the right side here, and this is within the caudal portion of the bulla, but there wasn't anything rostrally, so they would classify that as normal. So going on to their results, the causes of sinus disease. So the primary cause of sinus disease was 25% were primary sinusitis. They broke it down to subacute and chronic. I think their subacute was less than 2 months duration of nasal discharge, and chronic was more than 2 months duration. 53% were dental sinusitis, which I think probably is reasonably comparable with what I saw at Edinburgh and at Bristol. It's probably slightly biased given that all three institutions have a strong dental background, but I think it's probably about reasonable. About 10% sinus cysts, and then there's various little odds and ends, which I think probably reflects the way that we order our differentials usually anyway. There was a higher frequency of rostral maxillary involvement in dental sinusitis versus the non-dental group, but 98 to 90, it was a significant difference, but rostral maxillary sinus was involved in most of them. There was a lower involvement of the dorsal conchal sinus and the sphenopalatine sinus in the dental when compared to the non-dental group, so about 46.9 and 18.1 in the dental versus about 49 and 40 in the non-dental group. So it's more likely you're going to get the more dorsal sinuses affected. And they talked about whether or not that was due to the ventral location of the teeth relative to those sinuses, and whether the pathology just doesn't extend. When they looked at nasal conchal bulla involvement, overall, about 56% of the cases with unilateral sinusitis had nasal conchal bulla involvement of some degree, so whether that be damage or empyema. So about 20% of them had empyema, about 22% of them had damage to the ventral conchal bulla. Interestingly, the proportions were slightly different between the institutions, but I think they're roughly overall not a million miles out. And then if they looked at when they compared to the controls or the normal contralaterals, it was a very low proportion of affected nasal conchal bulla. So 6 out of 300 in the contralateral had fluid, and 4 had loss or damage. So there was only actually 3% as opposed to 50% involvement in the contralateral. So they used that as quite a strong statistic to say that actually the damage to these is usually related to there being sinusitis. So going on to the discussion, causes of sinus disease, dental sinusitis accounted for 53% of cases, 26% were just a primary sinusitis, be that subacute or chronic, and then 8% were sinus cysts, which was similar to a recent clinical audit, which isn't published, which was undertaken at Edinburgh, but it does differ from previous studies, which had a higher degree of primary sinusitis. They hypothesized that this might reflect the change in referral caseloads, whereas people are more likely to treat primary sinusitis at home and refer more difficult or refractory cases, or that the centres only CT the more difficult or refractory cases. When they talk about sinus compartment involvement, rostral maxillary and ventral conchal sinuses were most commonly affected in this study. Again, that could be a consequence of the more challenging cases being selected for treatment at referral centres, because those are the compartments that often aren't accessed in first opinion practice. There's decreasing involvement of other compartments in a caudodorsal direction. So the next most common was caudal maxillary. The next most common was the dorsal conchor or conchofrontal sinus, and the ethmoid and the vena palatine were much less commonly involved. As far as the dental sinusitis goes, the 09 teeth were the most commonly affected, which again would fit with what we see clinically. I think the thing that they found the most interesting was the rostral maxillary and the ventral conchal were also the most commonly involved in the non-dental cases, and they hypothesized this is probably to do with the anatomical predisposition and then the difficulty of draining of these sinuses. They talk about the fact that actually there is intercurrent nasal disorders in a high proportion of cases of sinusitis, so they had about just over 50%. They talk about the fact that nasal meatae and nasal conchae the conchal bullae are difficult to examine clinically, so CT enables better examination. Even things like examining the middle meatus can be challenging if you're not used to doing it endoscopically. Their previous publications have indicated that persistent infection of the nasal conchal bullae can be the cause of continued clinical signs. And they comment that can cause unilateral nasal discharge. So actually assessment of the nasal conchal bullae is important. And prevalence of nasal conchal bullae disorders hasn't been previously reported prior to this study. And I think it's quite interesting that about a third of cases of sinusitis have nasal conchal bullae empyema, and about 56% of the horses that have sinusitis have ipsilateral bullae changes. They hypothesize, and there's a couple of paragraphs on their sort of theories about why these bullae get destroyed. And I know Paddy has been known to wax lyrical about it previously. So there's quite a lot of hypothesizing that they abscessate and rupture, and then you get fungal infection in there and things. And I think a lot of that's a hypothesis, and it would be really interesting to follow these sequentially. Certainly their subacute primary sinusitis group, to follow those sequentially and see what happens to the bullae in the long term in those horses. But I think it's the case that you're probably not going to be able to do that. And obviously they comment that their contralateral nasal conchal bullae had a very low prevalence of disease, so that the changes in the bullae were assumed to be a consequence of sinus disease. So in conclusion, their multi-center study showed that dental sinusitis, primary sinusitis, and sinus cysts are the most common causes of equine sinus disease. The rostral maxillary and the ventral conchal sinus are the most commonly affected, which I think is interesting, and certainly for looking at radiographs, sometimes those can be, certainly the ventral conchal sinus can be more difficult to assess. The ipsilateral nasal conchal bullae are affected in 56% of horses. And I think the damage destruction is maybe less important than the 1 in 3 horses that have the empyema. And I lifted this sentence directly, that imagers and clinicians should be aware of the high prevalence of intercurrent nasal disease in horses with sinus disorders. So we need to be looking at these apparently, which we do anyway. And I think it ties in very nicely to the paper about the radiographic location of these, and it would be really interesting. And I tried to do this at Langford without much success, because we didn't seem to see that many horses with empyema of nasal conchal bulla. It would be interesting to go back and radiograph those and actually show how sensitive radiography is compared to CT. But once we came up with that project and got ethical approval, they all disappeared and we didn't see any anymore, which was annoying. Did anyone have any thoughts on that?
I was just going to say, I thought it was interesting what was concluded about the possibility for fungal infections as a potential cause, because I think some of the appearances of the bullae when they are, you know, distorted or destroyed, does share a lot of those features of sinonasal mycosis, doesn't it? So, but I can't think I've actually gone through with a case and had any feedback that there was a fungal infection.
Yes, I agree. And I think because they have that thickened mucosa and sort of gnarly appearance, don't they? I think one of their comments is that frequently when examining the middle meatus, you find fungal debris in there in cases where the bullae is atrophied, but I can't find that sentence at the moment. But they did comment on, yes, nasal endoscopy is sometimes shown Thin fragments of lace-like conchal bones that are possibly decalcified by chronic infection, along with insupportated exudate adjacent to the sites. I'm sure this is something about fungal infection as well, but I can't find that. There was definitely something about fungal infection somewhere. It was considered possible that the observed damaged or absent nasoconchal bullae were not caused by adjacent sinus disease, but instead a developmental abnormality or caused by some non-sinus related mechanisms such as mycotic rhinitis. However, when they examined the other one, the contralateral, it showed a very low prevalence. So,
interesting.
Yeah, I think it is interesting. We'll see. I mean, you never see, well, certainly my limited exposure to scoping these, you never see obvious fenestrations or rupture when you sticking the scope up in the middle meatus, but that could be my lack of skill with an endoscope. And you don't ever see actual holes in these, do you? You usually just see the fact they've withered away.
Yeah.
I don't know. I thought it was an interesting paper, and actually thought it was quite a nice little neat study that they did.
Yeah, but like you said, I found it jumped around a little bit. I think
this one less so than the other one, the other ones, but there was a bit of jumping around in this one, and there was a lot of personal communication or in the author's experience in there, which, I mean, certainly Paddy has probably scoped more sinuses than anybody in the world, but I do think that some of these maybe do need a bit more looking at from a scientific perspective. Cool.
Good.
I wondered your opinion about the prevalence of the primary sinusitis. Because it's almost half of the patients, if I understood well, or no, 25% overall.
Yeah,
25%. I don't have the impression that we have 1 out of 4 horses with sinusitis without any cause for this in our patients. Is this would you agree with the 25%? I mean, I always feel a bit uncomfortable with that when I don't find the cause for the sinusitis.
Yeah, and I'd be interested in what their criteria was for definitively saying dental, because having worked certainly with the Edinburgh team, they often will identify a tooth that's maybe equivocal, that maybe is showing early signs, that they will then sit on and re-examine, treat as a primary sinusitis and see what happens. So I don't know whether some of those horses with very low grade dental changes would be treated as a primary sinusitis, and then if it doesn't recur, it goes in the primary sinusitis box.
Yeah.
I don't know. I would say I probably do diagnose primary sinusitis relatively frequently. As high as 1 in 4, I'm not sure, but I would say that it's not infrequent that I would call tooth changes equivocal and say it's likely primary sinusitis, and that's probably from having worked with the Edinburgh team where they would sit on things a bit more.
Yeah, well, it's interesting because I think I'm biased because we have lots of dental cases, and so maybe I also have to feel a bit more confident if there is no tooth with the sinusitis, it's also fine.
Yeah. I don't know. I think, and certainly we've talked about this before amongst various one of us, that some dental specialists are keener to call things dental sinusitis than others, I think, is so I don't know.
Yeah, I think the presence of dental pathology is not necessarily always makes me. I very often think, oh, I'm not sure. I think this might be just because that tooth has been sitting in such a hideous environment for so long. And I sometimes sort of vacillate between thinking, and if I'm not sure, I tend to go towards the primary sinusitis, not wanting to sort of, condemn the tooth, I suppose, too much. So I think I err on sort of underplaying the teeth changes if I think that they could hang on in there if the sinus was treated. So yeah.
Yeah, I think I'm more on that side of the fence, definitely. And I think, yeah, that was definitely a Paddy thing of, I can't put the tooth back in, but I can treat the tooth more aggressively if it's still a problem. So
Yeah.
I tend to be a little more cautious, but that's me.
And can't you discriminate between the unilateral and bilateral? Because I think the primary may be unilateral as well. It doesn't.
Yeah, there is a selection bias in there because they only use unilateral cases. So I think they probably did have maybe a bit of a selection bias in there as well. I seem to have gone down a bit of an Edinburgh tangent today because 3 of these 4 papers are from Edinburgh.
They're all politics.
Yeah.
He's getting his pre-retirement run in. So this one I chose because we had a recent case that Jonathan and Mariana looked at that had some funny bone associated with a sinusitis. So I thought this paper happened to spring up. Again, they talk about sinonasal disorders and CT being required for extent of disease. They talk about changes in mineralization of the infraorbital canal and thickening of the maxillary bone being noted on CT in cases of sinusitis. I have to say, I usually comment on the mineralization of the infraorbital canal, shrug my shoulders and say, meh, we see it a lot. They also talk about scintigraphy, which I thought was an interesting little jump. They talk about the unexplained focal regions of IOU seen in maxillary bones on scintigraphy in horses with sinusitis. I have to say, I don't often include the head on my scintigraphies when I'm doing them clinically, but a lot of our clients do. So I've probably read more head scintigraphy since I started working for Vet CT than I had ever before. And we do see those IOU occasionally. We also see occasional low-grade facial swellings with sinusitis. I think there was a nice one that Laurence saw last week, actually, although that didn't really have sinusitis, did it? It just had a tooth, the one that we had both looked at last Thursday.
I don't
it had a hamster cheek.
I remember we discussed the case, but
yeah.
Wait, I have to think a bit about it. Yeah. Sorry.
And then they comment that we often see epiphora with horses with sinusitis, or can be seen. And then the other comment they made was that the maxillary septal bulla can be thickened and enlargement of the infraorbital canal can occur, which can make access surgically difficult. And then they went on to compare osteitis, human chronic rhinosinusitis, where you get osteitis, and in humans, when they CT them, if they have increased Hounsfield units within the bone, which they then said was increased bone density, it correlates with histopathological changes within the bone. I wasn't convinced that increased HU directly corresponded to increased bone mineralization, but that could be my ignorance. So if anyone knows better than me, please feel free to correct me. So their aims were to retrospectively assess CT images of horses, again with unilateral sinusitis, sinonasal disease, and for evidence of osteitis of the maxillary and frontal bones, the nasolacrimal duct, and the infraorbital canal. They assessed the bone thickness of the maxillary and frontal bones, and the diameter, measured the bone thickness and the diameters of the infraorbital canal and the nasolacrimal duct, and they compared that again with the contralateral side, so each horse acted as its own control. So they randomly selected 60 head CTs with confirmed unilateral paranasal sinus disease. They did linear bone measurements perpendicular to the bone at multiple sites. So they looked at the maxillary bone thickness at the caudal maxillary and the rostral maxillary sinus, and that was a defined location relative to a tooth. They looked at the frontal bone thickness within the frontal sinus, again at a defined location. They looked at the infraorbital canal at 2 sites, defined relative to the teeth, and they also looked at the nasolacrimal duct. Now, they did 3 measurements at each site where there was evidence of sinus disease in the adjacent compartment. If there wasn't sinus disease, they didn't measure. So especially with the more dorsally situated bony structures, so the frontal bone and the nasolacrimal duct, they didn't measure those in horses that didn't have any adjacent sinusitis. They measured the bone density of the maxillary bone in the caudal maxillary sinus at a fixed point, And they had 2 horses within their 60 cohort that had a repeat CT examination, and they actually measured both examinations in those horses. So this was just a diagram to show where they were measuring the infraorbital canal. So they measured both the bone thickness of the infraorbital canal and the overall diameter of the canal. Similarly, with the nasolacrimal duct, they measured the bone thickness and the overall diameter. They used the means of the 3 separate measurements at each site, and they compared with t-tests and Wilcoxon signed rank tests, because I can't spell. They compared those between the control and affected sites. So again, they had similar proportions of sinusitis. So 45 out of 60 of them were dental, so 75% rather than 50%. They had primary sinusitis or primary subacute sinusitis. They had some of those, that a lower proportion of those, and they also had 8 chronic sinusitis. They did only use cases that were unilateral, and they recorded soft tissue swelling in 7 cases and epiphora in 4 cases. Many images showed maxillary bone thickening and changes in the infraorbital canal and nasolacrimal duct. The bone was significantly thicker in affected sides at various sites, and that's on the next graph. And the bone density did not differ significantly between affected and control sites. In the 2 horses with repeat CTs, the bone measurements were of reduced thickness in the repeat CT compared to the initial visit. They kind of tried to say that meant the bone thickness was resolved, the increased bone thickness was resolving, but I can't imagine those horses underwent repeat CT because everything was fixed. So they're a bit sketchy on the details of why they got repeat CTs. Why did I put this table in? Do remind me. Oh, so they looked at the, so this is all their locations, and they looked at whether the percent of the thickness of the affected versus the control. So in the rostral maxillary, so rostral aspect of the maxillary bone, there was about 50% increase in thickness compared to the control side, and it was less evident in the caudal the bone in the caudal maxillary, and very much less evident in the frontal bone. The rostral measurement of the infraorbital canal was more significantly thickened, and the infraorbital canal diameter was more significantly different to the controls on the affected side. And then this is just a representation of the same thing, really. So it just showed you the asterisks indicate which ones were significant. So there was a significant difference in a number of measurements. The discussion, they talk about the study showing the presence of osteitis in diseased equine sinuses. Now, I'm not sure you can make the leap from thickened bone to osteitis without histopath, but that's just me being super picky. Manifested by significantly thicker maxillary bone and infraorbital canal bone thickness and increased diameter of the bones of the infraorbital canal and the nasolacrimal duct. They then go on to say it appears inflammatory, but there's no evidence of bone infection. Again, I'm not sure they can say that because they haven't got any histopath. So I'm not sure you can say why the bone's thickened. You can just say it is thickened based on the CT. But again, that might be me being picky as well. Maxillary bone osteitis can explain facial swelling in horses with sinusitis. They had facial swellings in 7 out of 60. So it's a very low prevalence of facial swellings. And it may also explain the increased radiopharmaceutical uptake in previous scintigraphic studies. I think that's probably fair. And they go on to say that the epiphora, which again, it was very low prevalence, may be related to nasolacrimal duct osteitis rather than pressure from exudate within the sinus, which I think, I'm not sure I would have thought it would be pressure from exudate within the sinus because the nasolacrimal duct is relatively contained within bone throughout the sinus. But obviously there's a very small number of cases, so the conclusions are limited. So the infraorbital canal, they went on to discuss a little bit more. So they discussed that there's osteitis and expansion of the canal diameter in affected sinuses. However, there's minimal clinical reports of trigeminal signs in horses with sinus disease. And I think that probably reflects that most of the modeling is on the outside of the canal. It would have been very interesting for them to measure the overall diameter and the diameter of the actual soft tissue core as well, because I don't think that that is narrowed. I think it just, the expansion happens on the outside in how I look at them anyway. Then they talk about the recent paper. I think it was I did look it up. I think it was in VRU. I think it was 2019, the paper that showed that morphological variations of the infraorbital canal have limited association with trigeminal mediated head shaking. So actually, effectively, they're saying we see this thickening of the infraorbital canal often. We don't think it's relevant to any trigeminal mediated badness, which I think is fair. They talk about the increased bone thickness of the maxillary septal bulla causing issues with sinusoscopy and sinus surgery, and that the enlargement of the infraorbital canal also causes problems with surgical access. And then they were stretching a little bit here, I thought. They go on to talk about how effective treatment of the cause of the sinusitis resolves the majority of cases of sinusitis, and that they assume this will cause resolution of the osteitis as well. But actually, they've only got 2 cases, so I think it's maybe a little bit of a stretch. Again, the assumption being that those cases probably wouldn't have had a repeat CT if everything was fixed. So I'm not sure they can go on and say that. They did talk about human rhinosinusitis quite a lot. So many cases are refractory to treatment. And in those cases, when they take bone biopsies, there isn't actually an inflammatory response within the bone. It's mostly thickening and increasing density and mineralization. They comment that the bone density didn't differ between affection and control sinuses. And also the limitation is that they haven't done any histopath on these. Now, I do wonder if they may start histopathing the bone flaps that they do. I don't know, that would be interesting, but actually most people are preserving the bone flaps now, aren't they? So it might not work. So their conclusions, after a lot of rambling. Osteitis with thickening of the sinus-related bones that appears inflammatory was found in most cases of equine sinonasal disease. This may lead to soft tissue facial swelling, epiphora, and increased radiopharmaceutical uptake in the sinus bones. The recognition of nasolacrimal duct, infraorbital canal, and maxillary septal bulla osteitis is useful in planning surgical intervention. My thoughts on this paper, I thought it was a little bit waffly, and I thought it was stretching a little bit, especially I think the osteitis to inflammation jump was a bit much for me. I don't know that you can make that jump without having histopath. I don't know what anyone else thinks. It could be being too much of a purist.
I think I agree with you, Lucy, to some extent. I don't know, you will know the authors of this paper better than I do, but I think if this was going into an imaging journal, they would be picked up on the fact that they're making quite a lot of assumptions about pathologic processes based on imaging findings, which, you know, we all know what, you know, you can do that in some cases quite easily, but I agree with you, it grates a little bit with me that they
have got an imager on the paper, but
yeah.
I was a bit.
I think it probably makes it, you know, it makes these papers much more digestible to the clinician, doesn't it, when you talk in real terms of disease processes that people understand rather than, you know, shades of grey. But I do agree with your point about that. And I think the sort of 2 cases that were re-CT'd, it's almost not worth putting in.
Yeah.
It's just, I mean, they may well have just been, you know, had good clients that said, can we stick the horse's head in while it's here? So they may have had complete resolution, but 2 out of 60 cases is virtually sort of meaningless, isn't it? So I think I'd have been tempted to cut that out and save the few lines that they
Yeah, I mean, I was surprised that bit got through the reviewers, actually. I would have thought the reviewers would have said, yeah, maybe that's not relevant.
I suppose the other thing, I'm just trying to, maybe my being silly, not having read it thoroughly enough, but I can't help but think that there's quite a lot of room for error in these measurements.
Yes, and they did 3, but they didn't do any repeatability thing, which actually, having been looking at grading scales for various other things recently, and having just trying to submit a paper of my own residents, I think a lot of journals are insisting on them having a repeatability now, because I think there is, and especially taking the mean, because you could have really widely differing outliers, couldn't you? And then
Yeah, I mean, I think, you can, you can obviously see some of them are thickened with your eyes without needing to measure them, but I think some of the minutiae that they're measuring, and then, how they to make sure that it's all sort of perpendicular, they do the MPRs, and I think, I'd love to see how they did that, because just because they're perpendicular to whatever it is that they made themselves perpendicular to, it doesn't necessarily mean that the structures that they're measuring, because of the different shapes of horses' heads, if you see what I mean.
Yeah.
And I think that's that's a nod towards trying to standardize it a bit, but it seems like there's quite some margin for error in there. Whoops, the cat's going to turn you all off.
I was like, is that a child? No, I think it's a cat.
The child will sleep, the cat won't.
Oh, the Labrador's asleep now. This is good. Yeah, no, I thought that, and especially when you get these horses with, I know they were doing it relative to a tooth, but when you get these horses with weird sinus anatomy, you're just not measuring the same thing. So,
yeah.
I mean, my take home is horses get thickened bone in the side that they have sinusitis in.
Yeah.
That's pretty much the only thing I'm taking from this
Yeah.
paper.
Yeah, it's kind of, I mean, it's interesting. I don't think it tells me anything I didn't already appreciate, or in any more detail than I think I had or needed. But it's interesting to have it documented. But it's semi-smacks of research for research's sake, a little bit. Doesn't really
Yeah,
get.
I think it's part of somebody's PhD, but
Yeah.
I could be wrong.
Yeah.
But yeah, it's interesting, and it is interesting to note, and then, like you said, to have it documented. But I think they've stretched a little bit with what I would conclude from that.
It's very comprehensive.
It's not the longest one we had to read. Sorry, I chose poorly. I'm going to quickly whiz through, because that one took a bit longer. Quickly whiz through the CT characteristics of paranasal sinus cysts, because actually I think this is the most interesting paper. And then if we've got time, we can talk about the cadaver rotten teeth one, but that paper angered me, so maybe not. So this is EVJ one, by means of change. This is out of Utrecht, I believe, and it is a resident paper. It's quite nice and concise. They start by talking about paranasal sinus cysts being a common cause of sinusal disease, and that CT gives more detail about location, morphology, and tissue composition. But there is a lack of current information about specific CT appearance of paranasal sinus cysts other than in intermittent case reports. So they were aiming to investigate whether there are unique features of paranasal sinus cysts in CT studies that may allow them to be differentiated from other cases of causes of sinus disease. So they looked at all horses with paranasal sinus disease over a period of time in their clinic, which I haven't written down, between 2011 and 2016, that had a confirmed final diagnosis by either surgery, or necropsy, or biopsy and histopathology. So they all had to have a pathological diagnosis. And they divided the horse into two groups, which was cyst, and that could be horses with one or more cysts, or other, so any horse with any other sinus disease, and that was based on gross pathology or surgical or histopathology findings. Everything had to have histopath confirmation. They performed the CTs in dorsal, under GA, and some horses had contrast, so they used 400 mils per horse of 300 mg per ml iohexol, and they injected that at 20 mils per second through a power injector. They didn't standardize the time after contrast injection that they did the CT, so they were between 2 and 7 minutes after the end of injection, which they go on to comment about in the discussion as to whether or not that was relevant. Sorry, I've gone way off piece. So the resident devised a grading system, and then the diplomat went through and graded all of the cases. They read them twice a month apart, and they evaluated the cases for the presence of a discrete linear or curved circumferential hyperattenuating wall-like structure, presence and extent of mineral attenuation within the lesion, presence of facial bone distortion, bone loss or new bone formation, and presence of contrast enhancement of the wall-like structures. They evaluated the maxillary cheek teeth, but They excluded those horses that had primary alveolitis ipsilateral to soft tissue attenuation, so any horse that had clubbing of the alveoli, widening of the periodontal space, and alveolar fracture or periapical sclerosis. They wanted to look at the bones surrounding the sinus was the reason for that. No, the cyst was the reason for that. And they actually looked at the attenuation within the soft tissue structure. So they did 3 freehand regions of interest in 3 different sizes, and that were as large as possible within the lesion that didn't encompass surrounding gas, streak, mineral, attenuating regions. So they compared the CT features and hand-filled units values between the cyst and the other groups, summarized the descriptive data so that the results are quite wordy and long. They used a t-test to compare the mean Hounsfield units, and then they looked at the frequency of abnormalities and compared those between the cyst and the non-cyst groups. So the descriptive stats, they actually only had 18 horses. Now, I assume this reflects the fact that they had histopathological confirmation for all cases, because they looked at a 5-year period, so you'd hope they would have had more cases, but probably getting the histopath confirmation was what limited. They had a reasonable, so more male than female, which I think reflects most clinical populations, a reasonable number of warm blood, thoroughbred horses. They all had similar surgeries. They all had sinus flaps. Most of them had histopath. One of them had, a couple of them had necropsy, and they had, all of them in the cyst groups had paranasal sinus cyst with various other things. And then they had a couple of neoplasias, a couple of ethmoid hematomas, 1 chronic primary sinusitis, some dental sinusitis, and traumatic sinusitis in the other category. Most of the horses had an average duration of clinical signs about 6 months. Most horses were unilaterally affected. There were some that were bilaterally affected, and there was different types of nasal discharge. Some had epiphorus, some didn't. The CT results were quite interesting. So all lesions in the cyst group were unilateral, which I think is interesting because sometimes you do see those little blobs in the other sinus with ones that you suspect have got cysts. In 7 out of 8 of the cyst horses, the cyst occupied more than 1 sinus compartment. They were most commonly in the conchofrontal sinus, but often spread to other sinus compartments. Mostly rostrally, actually. They didn't mention any in the ethmoid or sphenopalatine sinuses. In 2 horses, the cyst extended into the nasal passages or the conchal bullae. And then in the other group, the lesions were unilateral in 8 out of 10 of the horses. The cyst wall was soft tissue or mineral attenuation in 7 out of 8 horses, and then wasn't apparent in the remaining horse. In 4 horses, the wall was mineralized either entirely or interrupted focal linear or curvilinear peripheral mineralization. In 3 horses, mild hyperattenuation was observed within the periphery of the cyst, and they go on in the discussion to discuss whether that represents fibrosis or hemorrhage or focal islands of mineralization within the cyst wall. Most of the cysts contained variable amounts of soft tissue or fluid attenuating material. 3 had focal regions of mineralization, and then actually interestingly 2 had gas within them. One of those had previous trephination, but they weren't sure why. The other one was almost entirely gas filled. 7 of the cyst horses had contrast, and mild contrast enhancement was seen in 3 of these cases, but it wasn't consistent. So this image here is shows the hyperattenuating sinus wall, which was consistent with the paranasal cyst wall lined by respiratory epithelium with active osteoblasts, which apparently are these little dudes here, and multinucleated osteoclasts, which indicate new bone formation on the histopathology, which is consistent with this appearance here. And then they had another one that had this dentine-like material within it. And then this is a comparison between the 2 groups. So horse A had an extensive, and they've described it as a spiculated paranasal sinus cyst wall mineralization. So you've got this very sort of circular, fairly regular mineralization of the wall, which I think we do see relatively frequently in the cysts. And then they compare it with the amorphous mineralization, amorphous or swirling mineralization in the caudal maxillary sinus, which actually this horse had a very odd pituitary fossa meningioma which I'm not sure would be on my list of differentials for the reason for having fluid in the caudal maxillary sinus, but I assume if you can see the whole CT and you can see it extending from it, maybe it's more obvious. But they just point to the slightly different patterns of mineralization, but I'm not sure. You could maybe convince me they were the same pathology. I'm not sure they're that different. So interestingly, they saw bone distortion in both disease group, both the sinus and the other group, with similar frequencies. So there was bone loss in both groups. 8 out of 8 horses in the cyst group had bone loss, and 9 out of 10 horses in the other disease group had bone loss. Infraorbital canal destruction was common in both groups, and new bone formation was detected in most horses in both groups. So, which I think, to me, that was really interesting, because I often feel that bone distortion, so bone being pushed out of the way, would err me more towards diagnosing a sinus cyst, whereas if there's a lot of bone destruction, I'd be more going towards diagnosing something more aggressive. But it's really interesting that actually both groups had relatively similar patterns of bone loss. They did comment that the new bone formation was thicker, denser, and covering a greater area in the other group as compared to the sinus group. But that, I don't know, that was kind of made me think, maybe I'm not doing this right. They did see what they termed primary alveolitis in 3 horses in each group. And I think that was related to dental abnormalities. But one thing they did say, in the horses without dental abnormalities in the cyst group, they saw an increased alveolar bone volume in 2 horses. And they didn't see this at all in the other group. And they go on in the discussion to hypothesize if that might have something to do with the origin of the cyst. But I think that was a bit of a tangent that maybe didn't add a lot to me. I don't know. So the discussion, they went through the cyst wall being identified on 7 out of 8 horses on plain CT, either as a mineralized wall or a thick and soft tissue wall. And that's a combination, if I could spell, of ossified, hemorrhagic and fibrous tissue on histopology. They saw a similar CT appearance in the other disease group as well, so it's not pathognomonic. They had multiple mineralizations in the meningioma and the ethmoid hematoma that didn't follow the same pattern, so that should help with differentiation. They did find gas within the cysts in 2 horses, and they thought that was associated with a previous trephination in one case, but maybe not in the other. They weren't sure why. And they do comment that chronic sinusitis may be challenging to differentiate from cysts, sinus cysts, especially if you haven't got a reasonable wall to identify. They tried to use cyst contents to differentiate from sinusitis, but actually their Hounsfield units were very similar. Facial swelling was seen in both groups with a similar frequency. So bone distortion and cortical bone loss probably isn't a good differentiator either. Alveolar bone thickening was seen in some cases, maybe local new bone formation or maybe origin of the cyst. They kind of went on a bit of a tangent about that. And they found a much more equal distribution of cysts throughout the sinus compartments, which was confirmed, which was not consistent with previous literature. There was a previous large-scale study out of the Edinburgh group, which looked at about 300 cases as opposed to their 18. So I think I'm more enamored with the distribution of the Edinburgh group rather than theirs. So their conclusions were that the presence of peripheral hyperattenuating wall, a peripheral hyperattenuating wall with soft tissue or fluid content is helpful in identifying cysts, but it doesn't necessarily differentiate from sinusitis. The attenuations, the Hounsfield units, did not help in differentiation, and the expansile nature and cortical bone loss and mild bone production potentially doesn't help you either. So I think they were hoping to find something really definitive, like the swirling that you see with the ethmoid terminates, and they were a bit like, nah, there's nothing really particularly definitive that helps us differentiate it from anything else, which is disappointing, but I think it maybe makes me think a little bit more carefully about these sometimes when there's cortical bone loss, which is making me think it might be something more aggressive, and actually sometimes they are just cysts. I don't know. I thought it was useful because it told me that there wasn't anything particularly that sort of screamed cyst, which I think sometimes in these cases, it can be very difficult to differentiate between these and a chronic sinusitis. I don't know how anyone else feels about these.
Yeah, I like this paper. I think I liked it, and I thought it's made me I've got some new differentials for my cases like this, which is always good. I think I probably jumped to conclusions that things are cis when they could be other things based on the fact that common things are common. And this would make me a bit more, just step back a little bit about those things.
I always worry with cis. I always worry I'm missing something else. So.
Yeah, so it's a bit of a simplistic. I've always diagnosed them rather simplistically, I think, and this is sort of nice to just, like I say, just sharpen me up a bit. So yeah, but it was really nice. It's a nice complete. They've got the histopath and they've used contrast, and all the figures are really nicely described and clear, aren't they? It's a nice paper, I thought.
I forgot to go back to the contrast. So they discussed in the discussion, which I forgot to talk about, that only 3 out of 7 or 3 out of 8 of their cis actually, sorry, 7 out of 8 of the cis had contrast, only 3 showed contrast uptake, but they weren't sure at what time post contrast injection they'd been given, and they didn't grade overall contrast uptake. So I think they wonder if maybe it was a case of they may enhance, but we missed them, rather than they don't always enhance, which I think is an important point. And certainly without the benefit of the power injector, when I'm doing them standing, it's very variable, the speed at which the contrast goes in and what time the horse actually then gets scanned after the contrast has gone in, because you've got to get everybody out, you've got to make sure the horse is in the right position, and then you've got to press go. So I thought that was interesting.
Yeah.
I'm not going to trawl you through the last paper. I'm just going to skip straight to the conclusions, because I got very angry reading this paper because the numbers make no sense. The methodology is all over the place. Bits of the results are in the materials and methods, and the results are backwards compared to materials and methods, and it just maybe won't give you the limitations. So their conclusions were actually very straightforward, that changes highly indicative of periopical infection were identified on CT in 96% of the horses with histopathologically abnormal teeth. And radiographically, because they radiographed all the cadaver heads as well, they only found 50% of them. And that there were alveolar, because the part of the main difference between this paper and the same group's previous paper, which was clinical, is that these were cadaver heads and they took out the alveolar bone as well as the tooth. So they looked at the alveolar bone. They didn't particularly identify any specific CT change of the alveolar bone, but histopathologically, all the alveolar bone was abnormal that they had. So essentially, they've confirmed everything we thought about and everything they showed with their clinical paper, that if you think it's got an infected tooth on CT, it probably has got an infected tooth, with their criteria being assessment of the pulp horn for gas attenuating regions, assessment of the calcified apical tissues for gas in the apical space, and evaluation of the periopical alveolar bone for changes. Interestingly, they didn't have any very good examples of what they were using as markers in the paper, but essentially they confirmed what we already know, or what they already showed in their other paper. And I think that is the take home for this paper. Sorry, that was very brief, but you really don't want to get into it.
I wondered, I agree with all your points, but I also wondered how they got the heads through the ethical review committee, bearing in mind that it wouldn't appear they'd have permission to use them if they just took them out the rendering yard.
Yeah, that's a very good point, actually. I know that they used to go up and get them and then radiograph them in my x-ray room, which really annoyed me. But I don't know how they got that through, unless there was some sort of paperwork signed.
Yeah.
I don't know if for the rendering plant the horses were purchased by the rendering plant, and then is it the rendering plant that owns them?
Yeah, possibly, yeah.
I know that we certainly recently at Langford bought horses through the rendering plant for a similar study.
It may say in the paperwork when they sign them over that the horses may be used for research purposes, I guess.
Yeah.
It's just they're so picky these days on things like that, aren't they? If you haven't specified to the owner what it might be.
Even when you're doing retrospective blinded images from 2012, but yes. No, so I mean, if you haven't read the paper, I really wouldn't bother unless you have an afternoon and you want to get angry. But that was the conclusion. Read the abstract, it's all fine. Perfect. Right. Well, I do like to run to time, so it is 20:59. Unless anyone has any other comments, I'll wind it up and we can work from there.
That's great.
Well, nice to see you both. I'm going to stop the recording.
Thank you.
Oh, I would stop the recording if I knew how to work Zoom.
Thanks, guys. Bye.
See you later.
Bye. Thank you.